Hello again, everyone. So, this is Travis Rieder's In Pain, a bioethicist's personal struggle with opioids. A few highlights from the chapters that we've read, which are chapters 4, 6, and 7. Now, we have not even read, in this course, a quarter of the book's content, so I'm not going to try to summarize the entire text. I'm just going to mainly focus on some of the key details that come out in 4, 6, and 7. You can probably already gather, based on what we've read, that the book is a combination of autobiography and a combination of philosophical analysis. So Travis is talking about his own personal experience with opioid treatment and also trying to do some philosophical critique of the healthcare industry and how they handle opioid prescription. So here's the core background to the situation. Again, you can probably get some of these details from the text, but I've, omitted some of the material from our assigned readings. Now, I know Travis does summarize this story in the TED Talk that I posted on Carmen that you can look at. But the basic gist of it is Travis suffered a serious injury in a motorcycle accident. The way he describes it in the book is he was driving on his motorcycle down a street somewhat near his house, and he stopped at a stop sign, went through, and a van made a left turn into him while he was on the motorcycle, and essentially the front end of the van crushed his left foot, right? So if you're thinking about how you sit on a motorcycle and your legs are exposed, so the van's making a left turn, right, and basically just hits him straight on and crushes his left foot between the bumper of the van and his motorcycle. And when I say it crushed his foot, I'm not exaggerating. His foot was, on my understanding, just totally destroyed in certain places. And so he underwent 5 surgeries to repair his foot. And one of the surgeries was a free flap surgery where they basically took his foot had this giant hole in it, the way he describes it. I don't even really know exactly how to conceptualize what that would look like, and I sure as hell don't want to see pictures of it. But he essentially had a portion on the bottom of his foot where they're just the skin, the bone, and some of the muscle had just been so badly damaged there was just a hole there. And they to fix that, to patch it in a sense, they basically cut a chunk of nerve and muscle tissue from his thigh, and they put it in the bottom of his foot. And then over time, that bone and that muscle tissue and nerve tissue will be integrated into the foot and regain normal function. It's kind of hard for me to... I don't know the details of how all that works, and I certainly don't want to experience it myself. 5 surgeries is 5 more surgeries than I've ever had. But that's the gist of it. And that free flap surgery in particular is extraordinarily painful, both immediately after the procedure and persisting for quite some time. So that's what he was subscribed to opioids for, was in the aftermath of that free flap surgery. Now, the book gives a lot of these biographical details in much more depth than I've given. But it also talks about what it was like to be prescribed opioids, what advice he was given by various doctors, what his interactions with the doctors were like, and frankly, how this experience went very, very wrong, how he was ultimately not given great advice about how to taper opioids, in some cases just not given any advice, and then when he was really struggling with the withdrawal effects of trying to wean himself off of it, he had very limited resources for how he could get assistance with doing that. So there's a lot to unpack here. I'm just going to focus on a handful of the highlights in the main chapters that we read. The first chapter that was on a reading list was chapter 4, which is called The Opioid Dilemma. And this chapter is really the closest chapter in the book that we get to just, here's a philosophical breakdown of what the problem is. He calls it the opioid dilemma. This is the definition he gives in the book. The opioid dilemma is the very real, very difficult requirement that physicians take pain seriously and treat it responsibly, while simultaneously being responsive to the power and danger of a central pain relieving tool, one that is contributing to an epidemic of addiction, overdose, and death. And you can read the full context of that quote on page 69 if you wish. So this is pointing out that when we're talking about opioid prescription, physicians can make two kinds of mistakes. The first mistake they can make is overprescription, which is giving patients too many opioids. So when you overprescribe, it means some patients who don't need opioids get them, and it also means that some patients who need small doses of opioids get larger doses than they need. Both of these outcomes are bad because opioids carry a risk of bodily dependence, which can lead to addiction, and also, if not taken properly, they can lead to really serious negative health outcomes, including death. So overprescription is not so great. The other problem is not great either. It's underprescription. So underprescription occurs when you have a patient that actually has a really significant need for opioids, but they are not given those drugs as pain treatment. Now, when we talk about the opioid epidemic, we're generally talking about the problem of overprescription. But the only reason that we have the problem of overprescription is because we do want resources in the medical profession that can help us ease patients' pain, right? So the solution to the overprescription problem is not just simply, oh, well, let's use other stuff to manage pain. We'll just take opioids out of the equation. Well, opioids are really good at managing pain in certain situations. So if we take that off the table, we're going to have people like Travis after his surgery who are just in debilitating, near constant pain for a long period of time. That's not a great solution. So there has to be a balance struck between these two positions. We want to prescribe only to patients who have a need for opioids, and we want to prescribe them the right amount. That is easier said than done, as the general practice shows us. So here are some of the sources of mistakes you can have in opioid prescription. The first and most obvious one, patients sometimes just can't be trusted to use opioids properly. The reason for this is pretty straightforward. Well, the most common, there are many reasons, but the most common reason for this is fairly straightforward. Suppose that you're supposed to take a dose of 40 milligrams to ease your pain, and you're taking it, let's say every 6 hours. I don't know if that's what a normal dose would be, but this is just to illustrate the general point. The specific numbers don't matter that much. Well, after you've been taking that dose for a long period of time, your body will eventually adjust to that dose, and you might feel like you need more. You need a higher dose to deal with your pain properly, that like it's not having the same effect that it previously was. So maybe you up your dose to 50 milligrams or 60. Then if you do that too often, two things will happen. First, you'll be tempted to up your dose again at some point later, but also you'll run out of opioids before your prescription refill comes up, right? So if you had 4 weeks supply at this dosage rate, but you're taking a higher dose, you're going to run out before you're going to run out too early, and you're going to have to go back to your physician and get more. And that's going to prompt you to do things I kind of alluded to in the previous discussion of opioids, where I talked about kind of the erosion of trust, right? That's where you're going to get into where like you're making excuses to your physician, or maybe even lying to them about why you need more opioids, because you don't want to just admit that you're taking a higher dose than you're supposed to, because your physician won't like that. This is the kind of thing that makes physicians a little bit hesitant to trust patients with opioid use, and it's also one of the reasons why, because patients don't want to be judged or don't want to be, turn down the medication, right? They don't fully trust the physicians to give them what they want or what they feel like they need when they tell them the truth. So it's kind of a mess. But anyway, point being, patients often misuse opioids. They often do not take the proper dosages, or don't follow, or in some other way they don't follow the recommended regimen. Physicians are also not typically trained at all, and certainly not in depth, on how to properly wean patients off opioids. There's an interesting case that Travis talks about where they are trained to wean patients off of certain other substances, including benzos. And with benzos, the problem there is if you don't wean patients off that medication properly, there's a chance they'll die. And one of the professionals that he's talking with essentially says, look, I mean, if you don't help if a patient is not able to be weaned successfully off opioids, they'll be unhappy, like they'll suffer, but they're not going to be dead, right? But that's, kind of down, like the physician was, in other words, like very much downplaying the severity of the effect in the case of opioids and trying to carve out like a distinction between weaning patients off benzos versus opioids. But it's kind of a bogus distinction, because there are a lot of patients who are dying from not being properly weaned off opioids because they wind up becoming dependent on the drug and wind up taking too much of it and overdosing and in some cases dying. So it's, maybe not as many patients would die in that case, but it's still in many ways does have death as a side effect for some people. So I don't know. It was an interesting exchange, but not a particularly uplifting one. Point is, physicians don't get the proper education or training to wean patients off of the medication. Another reason why there can be mistakes in opioid prescription is epistemic injustice, something that we've talked about a couple of times now in this class. And the way that this usually manifests with respect to opioid prescription is that some patients, so in the text, Travis uses the example of two different patients coming in, one of which is named Darius and one of which is named Connor. He describes these patients in slightly different ways. And the intuition that he has, and which I basically agree with, is that most people are going to see Darius, the way he describes Darius, as being someone who looks like a junkie or an addict or someone who's just trying to game the system for some good drugs. Whereas Connor comes across as somebody who's a little bit tired, a little bit irritable, but has a serious need for opioids as a type of medication. And the actual particular circumstances of these two people, from what we know, is no different. It's all just based on kind of the language that they use to make their requests and and some other factors about their physical appearance. The fact that we don't take Darius's testimony as seriously as Connor's, at least at face value, looks like an instance of epistemic injustice and in particular testimonial injustice, right? Where we're just discrediting his testimony based on prejudice or stereotype rather than based on something meaningful. So that's a problem because this manifests in some significant ways. If you're a person of color, your chances of getting opioids for pain medication are much lower than if you are someone who's white. That's just a pretty clear fact about the way the treatments are distributed. And it's because, in general, it seems like pain reports from people of color are not taken as seriously as pain reports from people who are white. If you've watched the Bias in Medicine John Oliver episode, which I posted on Carmen several weeks ago, I believe it might have actually been at the end of Unit 1, there's a short excerpt in there where they talk about, the difference in understanding pain between people of color and between white people. And it's very strange. It's not specific to opioid medication, but it's very strange how the perception, there are some instances where a certain portion of medical students, when surveyed, thought, for example, that black people were more resistant to pain because they thought that black people's skin is thicker than white people's skin, which is wrong and also just weird. It's not just a false belief, it's an unusual false belief. There are all kinds of there were a number of weird examples that they gave from survey results given to medical students that sort of reinforce this idea that there's still some persistent stereotypes and other forms of prejudice that put you at an epistemic disadvantage if you're a person of color having a conversation with a doctor. And finally, the last major point, opioids are just not as effective at treating pain as they're often believed to be. They're really, really good at acute traumatic pain, like the kind of thing that might follow a free flap surgery. But when we're talking about treating long-term, chronic pain that's not as acute, they're actually not that great. And so one of the problems here with opioid prescription is that they've kind of become the go-to pain relief drug, but there are contexts where they're actually not even that good at what they're supposed to do. So this is another thing that contributes to overprescription. Now, here are a few of the important questions that come up as we're reading through these chapters and from Travis, and also considering the bigger picture issue of the opioid dilemma. First, who is responsible for setting and managing Travis's opioid regimen? And in particular, who is responsible for the process of tapering his use of opioids? Second, what aspects of the healthcare system contributed to his seeming abandonment by medical professionals in the wake of his opioid dependence? And third, what changes could be made to improve how healthcare professionals handle the opioid dilemma? So the first two questions here are mostly about how do we understand the problem? And then the third question is, well, what do we do about it? What would be some changes that we could make to try to resolve the opioid dilemma, or at least make progress, right? At least bring down the rate at which overprescription and underprescription occurs. We probably can't eliminate those things because, human beings are imperfect, and there's just going to be so many so many patients, right, who make claims to want opioids. You're never going to have perfect judgment, but I think it's safe to say we could be doing a lot better with this problem than we currently are. Now, one of the things that Travis spends a lot of time on, particularly in Chapter 6, is talking about the distinction between dependence, bodily dependence on a substance specifically, versus addiction, and being addicted to a substance or to some particular behavior. So importantly, Travis doesn't think that he was addicted to opioids. He thinks that he had developed a physical dependence on them, but that he was not addicted. So the dependence comes from, this strong withdrawal effect when he attempts to sort of taper himself off the medication. But the key, he didn't want to keep taking opioids. He was doing whatever he could to stop taking them. And that's not consistent with the behavior of someone who's addicted. A person who is addicted typically goes to great lengths to acquire the substance that they want to take and that they want to indulge in. So what Travis observed that he thought made clear he was not addicted to opioids is that he had, this strong bodily dependence on them that he developed from taking them over a long period of time in the aftermath of those surgeries, but it didn't affect his judgment about what he wanted to do, and it didn't impair his ability to stop taking them. Now, he suffered a great degree of physical discomfort in doing so, but what he refers to as his higher order desires, right? His desires, namely to, get off of these opioids because it would be better for him and for his family in the long run. Those higher order desires were not impaired by this sort of just base lower level desire of just, your body just saying, I'm in pain, please make this go away. Now, the reason that I point this out is because when Travis tried to get some professional help to help him taper the opioids, he was actually forwarded to addiction services. And essentially when he contacted them and tried to get help, they essentially said, oh, we don't taper people off of opioids. That's not what we do, right? So you can imagine the frustration here. You go to healthcare professionals and they're like, why don't you try addiction services? And then you go to addiction services and they're like, well, we don't really do that. Why don't you try your healthcare professionals? And you're stuck in this endless loop where no one's going to help you, right? not a good situation. Now, on the note of addiction, again, this is the kind of thing where like this occupies so much space in chapter 6, I feel obligated to say a little bit about it. There are 3 models of addiction. The first one is the moral model. This is probably the model that is the most intuitive. That doesn't mean that I think it's the one that's the most correct, but it's the one that I think when most people think of an addict or someone who's suffering from addiction, this is probably what they think. A lot of us associate a person who's an addict as being someone who's, weak-willed in some way and unable to stop doing something that is very obviously bad for them. The reason this is called the moral model is because we typically interpret this as like a failure of their character, right? In some way, it's a vice that they haven't been able to cull themselves on. So this is almost like a way of thinking of addiction through like the lens of virtue ethics, right? And understanding that an addict is a person who lacks certain virtues, right? Whether it be strength of will or quality of judgment or whatever, they have a moral deficiency that it's appropriate to criticize them for. The second model is the brain disease model. This model treats the mental illness that is associated with addiction as being relevantly similar to a physical disease. So just as, a physical disease is basically just an ailment of the body, the idea is that this is a disease that infects the mind. And so it's not the kind of thing that you can be morally blamed for. Just like you can't be morally blamed for, having cancer or coming down with the flu. I mean, there might be situations, like there are things that you can do, right, to reduce your chances of getting those conditions, but typically, even in cases where you were at a higher risk because of your behavior than someone else, we don't usually think that this represents a moral failing that you got a particular disease. So the thought is, same thing should apply to brain diseases. Brain diseases, like addiction, should not be the kinds of things that a person is blamed for, and they should just be treated in a clinical setting, the same way physical ailments are treated. Problem with the brain disease model, or at least one problem, is that it seems to take away any sort of agency from the person involved. And as a result, like when people conquer their addictions, they can't really be praised for that because it wasn't really, it's not the kind of thing that is connected to their agency in the right way. And Travis doesn't like that implication, or at least he kind of suggests, he does not take a stand on the brain disease model or the learning developmental model as to which is better. But it comes across to me like he doesn't like that implication of the brain disease model of addiction. The learning and developmental model says addiction isn't a disease, it's just a situation where the brain has learned the wrong associations between certain things, right? The brain has learned to fixate on some rewarding behavior too well, and as a result, it has actually sort of learned a maladaptive behavior. And so the solution here is to unlearn the relevant behavior, to change the associations, or to find some other way to mask or change the person's behavior to get rid of the addictive tendency. For whatever it's worth, of the 3, I probably lean toward the learning developmental model as being the best take among these 3 options. I'm no psychologist, but based on what I know, that would probably be the one I would roll with if I were forced to make a choice. Now, Travis doesn't say whether he endorses the brain disease model or the learning developmental model in on the whole, but he does reject the moral model of addiction, because the moral model of addiction characterizes, he and I think he's right about this, the moral model basically reduces addiction to just being entirely a failing of a person's character. And that just seems too psychologically simplistic, and it also has the undesirable upshot of essentially stereotyping people with addictions as being dysfunctional, incompetent, I've already said weak-willed. They're just in various ways undesirable people. And the moral model of addiction, that set of intuitions and judgments has been used to fuel a lot of stereotypes that we have about drug users, which is where we get to this idea of the junkie, as he calls it. So the junkie kind of, at least in Rieder's account, it originates from this idea of a hard drug user that, you know, was sort of like the target of the war on drugs, so to speak. This is the idea of a person who is, you know, unclean, kind of disheveled, not very smart or well educated, participates in criminal activities, and doesn't have a means of regulating his habits or behaviors. I did say his there. Usually the junkie, at least to my intuitions, usually male. Doesn't have to be, but usually, again, if we're thinking about the way that it's structured, that's usually what comes to mind when we think of the quote-unquote junkie. These perceptions, Travis points out, have played a role in how addiction services are staffed and maintained, and he thinks that the result of having this societal perception of addiction is that we generally don't have proper staff or proper funding for these services, because if addiction is a problem that originates in a person's poor character, then there's a tendency here to just say, well, it's really addicts' responsibility to help themselves, right? So if you take that view, where does the motivation to put tons of money into something like addiction services come from? Because, again, it's not really someone else's responsibility to correct their bad behavior. They need to do it themselves, or so the thought goes. But all of this is just a long-winded way of saying addiction services is not going to be an adequate solution to someone who has either a bodily dependence or an addiction to opioids. These facilities and services are not designed to help people taper opioids. So Travis was not going to get any help from them. Now, I want to step back for a second and take a moment to conceptualize what the core problem is with this issue. Not just the issue with addiction services or whatever, but the issue as a whole, the opioid crisis in general. I want to do a callback to our principles of biomedical ethics. So first, remember, the principle of non-maleficence says doctors should in general avoid causing harm. Now, doctors are not trained to help patients taper opioids. That means that when doctors prescribe opioids to patients, there are going to be cases where doing so causes harm to patients in the long run, because when they need to be tapered off the medication, they aren't going to be able to get the help they need to facilitate that. But another duty that doctors have is the principle of beneficence, which says that doctors should strive to promote good outcomes for their patients. One of those good outcomes is to avoid the patient experiencing unnecessary pain or suffering. So if you never prescribed opioids, you would wind up with situations where some patients suffer more from their pain than they ought to or than they need to, which would seem to violate this principle. So what we have here is a principle of non-maleficence says, well, we shouldn't really give opioids to very many people at all, because doing so clearly carries a significant risk of causing them harm. But then we have the principle of beneficence, which says, yeah, but we also need to, promote good outcomes for these people. And doing that means we need to try to treat their pain, and sometimes opioids are the only way to do that. So we've got these two different principles pulling in opposite directions. So the goal then is trying to find some kind of intermediary position that satisfies both of these principles, right? So what morality seems to require is that medical professionals provide opioids to patients who need them to treat their pain, which would satisfy the principle of beneficence, while also giving them the guidance necessary to taper their opioid use as their treatment progresses, which would satisfy the principle of non-maleficence. Again, the idea here is not that we're literally going to have perfect compliance with these principles, but that we move towards some kind of ideal balance that eliminates the underprescription and overprescription problems. So how do we accomplish these goals? What do we do? Now, this is not exhaustive of all the possible things we could do, nor does it cover everything that is mentioned in Travis's book, nor does it mention everything that you might come up with on your own, brainstorming about this subject. But here are a few ideas. One is improve physician training with regard, there's a typo in there, but I'll correct that before I post it on Carmen. Improve physician training with regard to opioid tapering. So in other words, just give physicians some basic training and education about the best ways of helping their patients wean themselves off the medication. Because right now it seems like they're getting almost nothing. And a little bit could go a long way in this respect. This seems like a sort of low-hanging fruit. It would be a very easy change to implement that would probably have significant results. Another thing we could do, designate a specific professional who is responsible for helping a patient taper their opioid use. In a portion of Travis's book that we read, he spends a lot of time talking about kind of the quest to figure out which physician or healthcare professional was responsible for his treatment. And it's actually very difficult to figure that out. And he sort of even says, I was kind of hoping at one point in the process that there would just be one person who was responsible for me, who I could blame. But there really wasn't any such person, right? There was no person who had that particular job. And among the people who were involved, it didn't seem possible to really single anyone out as having done anything wrong. It was, in other words, a systemic problem, a problem by committee, as it were. But one way we could get around some of this problem is to have a designated healthcare professional whose main responsibility was like pain management, and who was the go-to person for when you had someone who needed help tapering their opioid use. Another thing we could do is to try to use other medicine to treat pain when it's possible. Travis seems particularly, open to this suggestion as well, because he mentions a number of instances where alternatives to opioids would seem to work just as well or even better in certain contexts to using opioids. And some of those other medicines are much less severe and carry, a much, much, much lower rate of bodily dependence or addiction. So if you have situations where other medicine can be used to treat pain, that seems like the way to go. Another important one, and this is a kind of a callback to some of the other things that we've read in the course, you can improve awareness of biases in healthcare that lead to epistemic injustice and other forms of discrimination. With respect to opioids, this directly affects who's able to get opioids, how much they're able to get, and what their general healthcare experience with respect to their prescription is like. So improving awareness of these biases and giving people, more resources, perhaps through, human resources or bias training or something like that, just more information about how to combat that problem, again, could go a long way. This, admittedly, is something that you could make a case for being done independent of the opioid crisis, because there are other ways in which bias in medicine affects patients' experiences. But if we did this, it would have an impact with respect to the specific situation of opioid prescription. And not just within the field of medicine, but also outside the field of medicine, you have to continue efforts to reduce the stigma attached to drug use and addiction, because those stigmas still loom very large, and clearly knowledge of those stigmas affected some of Travis's behavior. He was cognizant in a number of instances of how that kind of perception that he was addicted to opioids. He didn't think he was addicted, but other people may have thought that. Travis's awareness of that stigma clearly influenced his behavior and influenced how he talked to people about it and what he did. I mean, he actually kept his story about his treatment involving opioids and his interactions with healthcare professionals to himself for a very long time, in large part because of a concern about what other people would think about the whole ordeal. So that, I think, is a good place to leave it here, thinking about what could be done to solve the problem. This is a huge issue. It's not going away anytime soon, so I'm sure that if you take other courses in the College of Pharmacy, you will hear more about this and more. The one thing I would caution you of, because I have talked to Travis personally about a couple of these issues, there is a tendency in healthcare to be a bit dismissive of the opioid epidemic, because it is fairly well known now, and there are a lot of people that have talked about it and discussed it, and there's a sort of tendency to think that, well, look, we understand the opioid problem, we've had conversations about it, whatever. But I would just remind you, the problem is still continuing. It didn't stop. People have become more aware of it, but actual fixes to it still remain elusive. So just because the problem is widely known does not mean that the solution has been widely implemented. So this is something you should keep in mind if you continue along in a career in healthcare and in a profession where pain management is part of the equation.